This is Dr. Jason Cayley, clinical immunologist and allergist in Toronto, Ontario. In this lecture, I'm going to be talking to you about the complement system. The complement system first evolved as part of the innate immune system. It is a series of heat-labile proteins that float around in plasma and are ready to be activated in the setting of an infection. These cylindrical-like proteins will float around and get cleaved through a process called proteolytic cleavage. The separate components of each complement protein have different functions. One of the ways that complements enhance the adaptive immunity is by augmenting the opsonization of bacteria by antibodies. As such, a lot of people think of complements as one of the many bridges between innate and adaptive immunity. There are a number of proteins that are considered complements. Many of these function together and cascade in what's called complement activation. There are three pathways that complements can cascade. The first pathway is called the classical pathway because it was the first one that was discovered. This requires an antigen and antibody complexes leading to complement activation. Complement activation then results in one of three things: recruitment of inflammatory cells, opsonization of pathogens, and killing of pathogens by enhancing the effects and activation of other, both innate and adaptive immunity cells. The second pathway involves something called the mannose binding lectin pathway. The mannan binding lectin binds mannose on pathogen surfaces. This also results in complement activation and the three effects that we talked about. The third pathway, which is probably the first pathway, but just happened to be discovered later on, is called the alternate pathway. Complements themselves are capable of binding pathogen surfaces and directly forming what are called membrane attack complexes. This also results in complement activation and the three effective functions that we spoke to about. So, if we look at these in detail, the classical pathway involves antigen-antibody complexes on pathogen surfaces. This involves the first complements called C1q, C1r, C1s, C2, and C4. The mannose binding lectin pathway involves MBL, MSAP1, MSAP2, C2, and C4. The alternate pathway involves binding of pathogen surfaces through C3, complement B, and D. C3 convertase breaks up these complements into several components. If it happens to be C4a, C3a, C5a cleaved from the bigger C4, C3, C5, it activates peptide mediators of inflammation, causing phagocytic recruitment. If it happens to be primarily a C3b response, it binds complement receptors on phagocytes, enhancing opsonization of pathogens. This also results in a removal of immune complexes. They also go through what are known as the terminal complement components. This includes C5, C6, C7, C8, C9. These form the membrane attack complex, which causes lysis of certain pathogens and cells. You can think of this as little punch holes that are made on the surface of bacteria and microorganisms. As I mentioned, all complement proteins require proteolytic cleavage to be formed into a smaller breakdown product, which is often denoted with the small letter A, and a bigger breakdown product, which is denoted by the small letter B. Let's take the classical pathway, for example. Activated C1s cleaves C4 to make C4a and C4b. C4b then binds C2, which is cleaved by C1s to C2a and C2b, forming the C4b2b complex. C4b2b is an active C3 convertase, meaning that it cleaves C3 to C3a and C3b. This binds to the microbial surface or becomes the convertase itself. One molecule of C4b2b can cleave up to 1,000 molecules of C3 into C3b. Many C3b molecules bind to microbial surfaces, forming a nice little adhesion to allow the membrane attack complex to form. The complement system clearly participates in the expression of innate immune responses. So, Let's now talk about the alternate pathway. Certain microbial products can directly activate the production of activated C3 and ultimately the membrane attack complex. Let's see how this works. In the alternative pathway, C3 undergoes spontaneous hydrolysis to become C3 bracket H2O end bracket. This binds to factor B, allowing it to be cleaved by factor D into BA and BB. The C3H2O-BB complex is a C3 convertase as well. It cleaves more C3 into C3A and C3B. C3b is rapidly inactivated unless it binds to the cell surface. Factor B binds non-covalently to C3b on a cell surface and it is cleaved by BB by factor D. Now, I don't want you to get too lost in the details here, but suffice it to say, none of these things cannot work in isolation, but once things are converted into active convertases, they have protease activity and cleaves further complements. A clinician needs to know that in this pathway of forming a membrane attack complex, there are patients that are missing certain components of complement. Complements are often measured in the setting of autoimmune disease, such as lupus, to determine activity. However, in the setting of immune deficiency, we have to really understand the function of the membrane attack complex and how it is formed. If we go fast forward a little bit and look at the assembly of the membrane attack complex, this generates a pore in lipid bilayer membranes of microorganisms. Once you've had all the C3 activated and all the proteolytic activity coating cells, what ends up happening is that this forms as a nidus for C5b binding to C6 and C7. This involves the formation of a bigger cylindrical structure. The C9 molecules bind to the complex and polymerize. These are sort of termed the terminal components of the complement system. The terminal components of the complement system will form a pore on the membrane, allowing the cell to be killed by not enabling it to maintain homeostasis of its electrolyte concentrations. There are multiple problems that occur clinically when the complement system does not function optimally. Factor 1 deficiency is one of the clinical disease entities that someone can also encounter. In patients with C1 genetic factor 1 deficiency, because of uncontrolled complement activation, the complement proteins rapidly become depleted and people suffer repeated bacterial infections, especially with ubiquitous pyogenic bacteria. Patients with terminal complement deficiencies encounter more infections such as meningitis from Neisseria meningitis bacteria and other opportunistic pathogens. Anyone with recurrent meningitis or opportunistic infections with bacteria should be considered for a complement deficiency. A way to test this is by using something called the CH50 measure. The CH50 measure essentially checks how quickly it takes for half of the complement function to occur. The CH50 is in fact the best screening test for deficiency of both the classical and terminal pathway. Hemolytic activity of the complement system is measured by hemolysis of sheep red blood cells or erythrocytes sensitized by specific antibodies. One CH50 unit is defined as the volume or dilution of serum that destroys 50% of erythrocytes in the reaction mixture. Again, how the cells are destroyed or how they're lysed is by the formation of the membrane attack complex. There is another test called the AH50, which is the analogous test to measure the alternate pathway function. However, this test is only available in specialized laboratories. A low level of CH50 or AH50 warrants further evaluation. A low level of both AH50 and CH50 suggests a deficiency in one of the more components shared by both pathways, i.e. C3 to C9. A low CH50 suggests deficiency of a classical or terminal C component, meaning C1 to C8 deficiency, in which case the CH50 value is approximately 0. You'll recall that the initiating cascade all requires the lower level number of complement proteins. For example, the C3, which is critical to forming and causing the nidus for the rest of the membrane attack complex to form. A C9 deficiency, which is also more common, shows a CH50 value that is approximately half of the normal value. A low AH50 level suggests a deficiency of factor B or factor D or properidin. These are components that rely on alternate pathway only and do not play any part in the complement classic pathway. Immunochemical methods are used to demonstrate specific component complement deficiencies. In most labs, a C3 and C4 level are obtainable. Other laboratories are able to do tests for the other complement numbers. A low C3 and normal C4 level suggests activation by the alternate pathway. This is because C4 is not used in the alternate pathway. ANA is generally negative in immune complex diseases caused by complement deficiency. Function of the mannose binding lectin pathway can be assessed with enzyme-linked immunosorbent assay called ELISA, which detects C4D bound to mannan that is coated onto a plate after the test serum was incubated in the plate. Serum levels of MBL and MASP1 and MASP2 can be measured immunochemically, and some chemical labs offer such measurement techniques, but this is not widely available. Other special tests include measuring actual factor levels of some things like factor H factor. Now, how is this important? Well, in anyone with recurrent sinopulmonary infections or unusual infections such as meningitis, particularly with Neisseria, one should work up for complement deficiencies. There is even a case to be made for screening all infants and newborns for C3 deficiency by using microarrays. Unfortunately, treatment for complement deficiencies does not really exist. Only supportive therapy is available for most complement deficiencies as they pertain to immune deficiency. C1 esterase inhibitor can be used for hereditary angioedema, but again, this is beyond the scope of this lecture. All routine vaccines are recommended in the setting of complement deficiency. This includes both the meningococcal and pneumococcal vaccines. Make sure that patients receive their appropriate boosters to these vaccinations so they can prevent respiratory tract infections and more serious infections such as meningococcal meningitis. All patients with this should eventually be referred to an immunologist. This concludes the immunodeficiency lecture on complements.